So good afternoon, everybody. I will be speaking about vessel analysis and device sizing using IVUS. So we've been discussing for so long about what are the clinical uses of intravascular imaging for vessel analysis, and it does have a major role to play in pre-intervention situation. When you're looking at the lesion severity, you're looking at why exactly this occurred. Is it a stable CAD and ACS, a restenosis, a stent thrombosis? And then when you finally decided what it is and what you want to do, you would also want to use it during the PCI guidance to look at what is exactly the stent size that you want to use, what is the associated devices you want to use to settle this, and you want to look at the end of the PCI for optimization and for looking at, are there any complications? Have you achieved a great MSA? Is there a good expansion? So when we talk about the use of IVUS in vessel analysis, we talk about quantitative and qualitative. Quantitative, you want to look at the size, the measurements. Qualitative, you want to look at the morphology. So what is it that you want to look at in quantitative? The lesion length, the lumen, the vessel, the plaque, CSA, the neointima, the eccentricity. And when you look at the reference segment, again, you want to see what is the CSA there. So how exactly did this compare with that? And you want to look at what is the area stenosis there. So you can decide whether you actually want to intervene in this particular patient. Again, qualitatively, you want to look at the morphology and the composition. So what about the composition? You want to see if it's a calcified lesion, a fibrous, stable lesion, or a fibrofatty lesion. And for the morphology, you want to see if this was an ACS, is there a thrombus, a rupture? Is there a vulnerable plaque there? If it's an ISR, you want to see if it's atherosclerosis. You want to see if there's a dissection, a tissue prolapse at the end, a malopposition or a stent fracture at the end. So all of these things can be looked at very well with IVUS per se. What are the problems that we solve when we look at a procedure, when we're going for a procedure? So we want to know, first thing, how long is the lesion? The second, what is the type of plaque, and does it actually require some kind of an atherectomy before you want to proceed prior to stenting? What kind of bed preparation do you need? And finally, what's the size of the vessel and what is the size of the stent that you require to do that? So first, pre-stent workflow, establish the lesion length and define a healthy landing zone. So you would want to look at a zone which is either totally healthy like the first, or you would look at a zone which has less than 50% plaque burden. Next, you would assess the morphology. And if you saw fibrotic tissue, you might think of using a cutting balloon. And if you saw calcification and your score was high, you would think of some kind of an atherectomy. So that's important, and IVUS can really pick up the calcified ring very well. So calcium is quantified by measuring the arc that it encompasses. It's also classified by what is the location. Is it superficial, closer to the lumen, or is it deep and closer to the adventitia than to the lumen? And henceforth, if your calcium scoring came out to be high, you knew that you would have to upfront consider an atherectomy. Now, if it's eccentric calcium, what would you think of? Your arc is less than 180, your thickness is less than 0.5, and your length is less than 5. So you would think that maybe I can get away with just an NC balloon, or a cutting, or a scoring balloon. And if you saw that there was concentric calcium, or if you saw that you had nodules of calcium, you knew up front that you would need to take in a rotational or an orbital atherectomy, and maybe sometimes even a shockwave lithotripsy. Again, it's very helpful in analysis of in-stent restenosis. Are you dealing with an intimal hyperplasia? Are you dealing with nuanced atherosclerosis? Is there a lot of calcium underneath the stent, which has made the previous stent underexpanded? So whatever it is, it would help you with the device selection. You could define the reason why the stenosis occurred, prepare the lesion according to that using cutting, scoring, or atherectomy, assess for all mechanical factors, and finally treat it either with a drug-coated or a drug-eluting stent. And then finally, optimize the result using an IVUS. Again, vessel analysis, it's very important because with IVUS, you can even define whether it's a plaque rupture or a dissection. With plaque rupture, you would see the communication point, the cavity, the thrombi. With dissection, you could actually define the intimal flap. And both of them angiographically, they sometimes look very similar, but IVUS would help you to decide the two. The pattern in a rupture would be inward to luminal. For a dissection, it would be outward to medial. Again, hematoma, sometimes you see this angiographic picture and you're not sure what it is. So it would help you to decide the hematoma while you're doing the procedure. And also sometimes give you hematoma treatment guidance. Many times when you're troubleshooting such lesions, you can use a cutting balloon and do a fenestration and end up with a good result. Bifurcation stenting, again, the Achilles heel of coronary intervention. And now we have such excellent results with bifurcation, and that's because now we are doing imaging. Especially in cases of left main bifurcation, we really need an excellent result, defining the size of these stents, where they're going to land, optimizing them post-procedure, making sure that your neocarina is well covered, making sure that you have no edge dissection, making sure that your side branch does not have any struts across it, leading for fenestrated restenosis later. So in bifurcation, imaging really helps you get an optimal result. So the pre-stent workflow, the final thing is to measure the vessel size. You would want to look at the distal and the proximal vessel size so as to size your stent. So I have a stent optimization. You need a complete stent opposition, a well stent expansion, no stent edge dissection at the end, and a full lesion coverage. So that's what we are looking at when we use IVUS. Stent optimization is very important because if you look at the target vessel failure, there's a real difference if you don't optimize your stents. And optimizing would mean that all the three criteria were met. The MLA in the stented segment greater than 5. And if you looked at the break burden, 5 millimeter proximal and distal less than 50%, and no edge dissection involving the media. Post-stent, you would want to see if you had any kind of a geographic miss or an edge dissection. You would also want to check for any malopposition, check for the patency of the side branches, and check for an optimal stent expansion both proximally and distally. So the IVUS-guided IPSP strategy is very important. Imaging-guided pre-dilatation, so used to deal with the calcification, the break burden, the configuration, this opening of side branch, stent sizing, landing zone configuration, lesion length, and stent opposition, and also look for any procedural complication. So this is just a case to elucidate it. 66-year-old male patient, known case of hypertension, diabetes, COPD. He had acute kidney injury on CKD. His creatinine was 5.6 before the angiogram, came down to 2.7, and then the angiogram was done in a different centers. The patient was grossly symptomatic. He was post-angioplasty to both the LAD and the RCA. It was done way back in 2014. The echo revealed a wall motion in LAD RCA. He had an ejection fraction of about 25% only. His angiography revealed a proximal 90% stenosis. The mid-stent was patent. Again, the circumflex had osteoproximal 80% stenosis. The RCA had an osteal lesion, 100% in-stent restenosis. He had a syntax score of 33. Based on this, he was referred for a bypass surgery. But with CKD and a very poor LV function, he was deemed an extremely high risk, so the patients and attendants, they opted for an angioplasty. Now this was the angiogram of the patient, the RCA 100% occluded. This was the left system. You can see the proximal disease in all the three arteries. Now after discussing with the heart team and the constantly symptomatic patient and denial repeatedly for a bypass surgery, we decided to do a mechanical circulatory support assisted PCI. Considering his creatinine levels, doing a CTO of the RCA would have taken long. And the risk of a nephropathy would increase if we did everything in a single setting. So we planned to stage the procedure, attempting the RCA first. Also, attempting the left main first without any support would have been like attempting the single surviving vessel. We planned to open the CTO. We thought it would not hamper his overall hemodynamics. We opened the CTO of the RCA. Subsequently, we planned for a left main LAD and ramus bifurcation stenting. This was the CTO of the RCA, and this was after opening it. We waited for 3 days. His creatinine levels remained stable at 2.3, and then we planned a left main bifurcation with mechanical support and IVUS guidance to decrease the contrast load. Now, IVUS has a definite edge in left main interventions and also in patients who have chronic kidney disease. Also, to decide the landing zones in diffusely diseased arteries like these and plaque modification devices required to prepare the bed. So this was the LAD mid-segment. We found the proximal landing zone, distal landing zone, diffuse disease, but we found a region with 42% plaque burden. This was the tightest segment of the LAD with the MESO2. This is post-stenting LAD, distal edge stenting, post-circumflex ostium, no overhanging struts. So well-expanded stent and well-crushed stent. And we did a mini crush for this patient. Incidentally, this was done live at Sky Phoenix. Did a mini crush for him, and this was the final result. So, this patient had a creatinine of above 5, severe LV dysfunction, left main bifurcation disease, CT of the RCA, very high surgical risk, high risk of a contrast-induced nephropathy with PCI as well, especially while doing a CTO and a left main bifurcation. Staging the procedure helped in recovery of his kidney function test. Mechanical support was very important to avoid an altered hemodynamic support while inflating the balloon in the left main. Patient did not crash during the procedure. Renal perfusion was well maintained all throughout the procedure because of the impeller support. IVUS was particularly useful in sizing the stent to decide upfront two-stent strategy, the landing zone in left main mid-shaft, because an off-tail placement usually requires more dye, and final adequate distal landing zone as there was diffuse plaque in the LAD throughout. So deciding the plaque modification technique, we used a cutting balloon because we had a 180-degree arc for the fibrocalcific lesion in our case, and also post-procedure to assess an adequate stent deployment and stent optimization, including proper crush and excluding complications. Ladies and gentlemen, thank you so much.